Many thanks for joining to our virtual Grand Rounds in Radiation Oncology. It's a pleasure having you yet again, and even one day earlier. You know our format, the virtual Grand Rounds. We are running now for about 1.5 years. We always aim to present you the latest science presented by the very top speakers in a very interactive format. Reminding you again, we usually have our Grand Rounds lecture on the first Wednesday of a month. Today, we had to organize it one day earlier. So again, many thanks for joining at this, call it, unusual time. Um, Many thanks already again for the support. We are being endorsed by the societies, the Astro Society, SASRO, and the German Society for Radiation Oncology. I also would like to remind you again that all lectures are being recorded. So if you have missed any of them, please go to our webpage and you can see the recordings. Today, we're having a topic which is kind of unusual for our virtual Grand Round in Radiation Oncology section. Usually, we discuss clinical trials, mostly randomized clinical trials. Today, it's about the effect of these clinical trials on our health economic system. You know that we are having seen and observed tremendous progress in the field of cancer research, and that also changed the way how our patients are being treated. That is in the field of radiation oncology, but also in particular in the field of medical oncology, so new drugs entering our market. The question is, what is the value which is being provided for, not for an individual patient, that's a clinical trial, but for our society? And this is an article which has been published in The Lancet in just a few weeks ago, the population health impact of new drugs recommended by the National Institute for Health and Care Excellence in England during a period of 20 years. It's a retrospective analysis. And this has been the kind of take-home message. Despite there was a kind of tremendous progress for individual cancer patients, which might be cured by this progress, this progress comes at a cost that the same amount of money can only be spent once, at least in a healthcare environment which is which is limited, and that the costs of these drugs are so high that maybe even there's a loss in quality of life years, and that was being estimated by in total to 1.25 million. And you can see a circle on the net health effects, which was being the worst for medical oncology, or for drugs in the field of oncology. So I'm very happy having the first author of that article with us who are going to present and discuss the results. Dr. Huseyin Nac, he is being or is an associate professor for health policy at the London School of Economics. He has studied a PhD in pharmaceutical policy, again at the London School of Economics and Political Science. He has done 2 fellowships, both in Harvard, and he has been working on that study for several years. We had a short discussion before that this was quite controversially received. I found it super important, interesting. So I'm looking forward to the presentation and encouraging you again to kind of have a discussion thereafter. Naci, many thanks for joining. Many thanks for taking the time for presenting and discussing your work with us. The floor is yours.
Thank you very much, and I hope you can see my screen and hear me well.
Perfect.
Dr. Guckenberger, thank you again for this invitation and for your kind introduction. So the title of my presentation is Trade-offs in Paying for New Drugs in Health Systems. Um, Let me make sure that the tech works here. So before I begin, I'd like to acknowledge my collaborators from the US and the UK in this study, and the Commonwealth Fund, which partly funded this study. Let me begin with some background. The context of this study is the National Institute for Health and Care Excellence, or NICE, which was established in 1999 to address so-called postcode lottery in access to new drugs in England. NICE is the health technology assessment body in England, and it evaluates new drugs following regulatory marketing authorization. And NICE's remit is to make funding recommendations for the National Health Service, or the NHS, in England. And local decision makers in England are mandated to make funding available for treatments recommended by NICE within a specified time frame. NICE bases its recommendations on an assessment of population benefits and value for money. In fact, NICE explicitly states that its assessments consider the opportunity cost of recommending one intervention instead of another. What this means is that NICE, in theory, recognizes the fundamental concept of opportunity cost in health systems. If we allocate limited resources to pay for certain treatments or technologies, these resources are no longer available to pay for other services and treatments. NICE's assessments compare the clinical effectiveness and cost effectiveness of new versus existing treatments. NICE measures health benefits, or in other words, clinical effectiveness, in terms of quality adjusted life years or QALYs, which are an overall measure of health. These weigh the life expectancy of an individual with an estimate of their health-related quality of life. In that one QALY equals 1 year spent in perfect or full health. As mentioned in the earlier slide, NICE assessments routinely include comparative cost effectiveness analyses. NICE estimates the new treatment's costs and how much benefit it produces compared with the next best alternative. And the simple formula I have on this slide shows how NICE evaluates a new treatment's cost effectiveness compared to existing alternatives. This results in an incremental cost effectiveness ratio, or an ICER, which is expressed as additional money per each additional QALY gained. So in other words, how much more does the new treatment cost to generate 1 more year in full health? NICE in England typically considers drugs with an incremental cost effectiveness ratio between £20,000 and £30,000 per QALY gained as cost effective. We can think of this as NICE's approval or funding threshold. If a new drug's additional costs are not higher than £30,000 for generating an additional year in full health compared to existing alternatives, NICE typically considers this to be cost effective and recommends it for funding. However, there is no empirical evidence to support NICE's current funding threshold. This brings me to the motivation for our study. Several analyses over the past decade have examined the relationship between healthcare expenditures in England and health outcomes. In other words, researchers have examined what happens to health outcomes when health expenditures either go up or down over time. And what these analyses have revealed is that the health service in England spends approximately £15,000 to generate 1 additional year in good health. And it's important to note that this figure, this £15,000 per QALY, is accepted by the UK Department of Health and Social Care. And the department routinely uses it when evaluating the impact of new policies, for example. The implication of this figure is that paying more than £15,000 per additional QALY would represent poor value for money and would do more harm than good to population health. So against this background, our aim in this analysis was to quantify the net health benefits of NICE recommended new drugs, considering both the value for money of new drugs and the opportunity cost of resources required to pay for them. So our objectives were threefold. First, we wanted to document the value for money of new drugs recommended between 2000 and 2020. Second, we wanted to characterize the health benefits of new drugs over time and by therapy area. And third, we wanted to estimate the population health impact of NICE recommended new drugs by therapy area. In terms of our methods, let me try to summarize our methodological framework using just a single slide, using a very simplified illustrative example. So the amount of NHS spending for a new drug is determined by NICE's funding threshold for recommending that drug. Using the NICE appraisal reports, we can see how much health or how much health benefits we can expect from that amount of spending on that drug. And using the information I shared in the earlier slide, we can also estimate how much health the NHS can generate for the same amount of money if it was reallocated to other services in the NHS. The difference between the health that is gained versus what could be gained by reallocating the funding to other services is the net health effect of a drug. So let's say that NICE recommends a new drug for funding at £30,000 per additional QALY. We know that NICE expects that the new drug will produce one additional year in full health for that amount of money. Because we know that the NHS can generate one additional year in full health for £15,000 through existing treatments and services, this means that reallocating the £30,000 to the NHS could have generated two additional QALYs, resulting in -1 QALY. Now, what would that mean at the population level? If, let's say, 1,000 people receive the drug recommended by NICE at this funding level, NICE would expect that the new drug produces 1,000 QALYs for that patient population, but that same amount of £30,000 could have generated 2,000 QALYs if it was reallocated to other treatments and services in the NHS. So that difference between those two numbers reveals the population health impact of the NICE recommendation. So to implement that methodological framework, we did three things in this paper. First, we identified all new drugs and approved indications of those drugs that were appraised by NICE between 2000 and 2020. Second, we systematically reviewed NICE assessment reports, which are publicly available, and identified the value for money and health benefits associated with these new drugs. And third, we estimated the number of people who received these NICE recommended new drugs during that time period using proprietary data from IQVIA. I will be very happy to go over our methods in more detail, but in the interest of time, I will jump over to the results. So now I will summarize our findings very briefly. Our study sample consisted of 183 new drugs assessed and recommended by NICE between 2000 and 2020. These drugs were approved for use in 287 indications and assessed in 339 separate NICE appraisals. So this formed the basis of our analysis. It's important to note that cancer drug appraisals accounted for nearly half of all appraisals in our sample. And more than half of appraisals were actually published between 2015 and 2020. When looking at the health benefits of new drugs recommended by NICE, the median quality-adjusted life year gain across all appraisals was 0.49 or 0.5, equivalent to an additional half a year in full health. And there was a modest increase in median QALY gains associated with new treatments during this study period. There was significant variation, however, across therapy areas, ranging from small additional QALYs gained for the vascular system drugs to large improvements for appraisals of anti-infective drugs. Here are our findings for the value for money, or in other words, the cost effectiveness of new drugs recommended by NICE. The median incremental cost effectiveness ratio for recommending new drugs increased from the earlier periods to the later periods in our study. And the median ICER varied considerably by therapeutic area, ranging from being very cost effective for appraisals of anti-infective drugs to not very cost effective with a median value of £30,000 per QALY gained for appraisals of oncology drugs. During this time frame, we estimated that about 19.82 million patients received new drugs recommended by NICE. And let's first look at the costs associated with that use. In total, the use of new drugs resulted in an estimated additional cost to the NHS of 75.1 billion. And the area that contributed most to these costs were immunology at 25.7 billion, followed by oncology at 22.7 billion. Let's then look at how much the new drugs generated in terms of health benefits. New drugs generated an estimated 3.75 million additional QALYs in the health system over that 20-year period. Of these, an estimated 1.1 million additional QALYs were attributable to new drugs used in immunology, and 0.64 million additional QALYs were attributable to those used in oncology. Let's now look at what the amount of money spent on new drugs in these therapy areas could have generated if that money was reallocated to other treatments and services in the NHS. In total, the NHS could have generated 5 million QALYs between 2000 and 2020. Of these, 1.71 million could have been generated with the money spent on immunology drugs, and 1.51 million QALYs with the money spent on new cancer drugs. And when we compare the amount of health generated with the money spent on new drugs and the amount of health that could have been generated if that money was spent on other treatments and services in the NHS, this is the picture that emerges. Most therapy areas had a negative net health effect, with the use of oncology drugs accounting for a loss of 0.87 million QALYs at the population level. Importantly, the net health impact of new drugs became progressively more negative over time, driven primarily by the net impact of wider use of oncology and immunology drugs, which you can see in the figure in bright yellow and light blue. And overall, the cumulative population health impact of drugs recommended by NICE was negative over this 20-year period, resulting in a net loss of approximately 1.25 million QALYs. In terms of conclusions, our analysis revealed that a growing proportion of NICE appraisals recommended funding of new drugs at levels considerably above the health system's opportunity cost threshold, and overall the cumulative net benefit of NICE recommended new drugs on population health in England appears to be negative. Of course, this was a very quick overview of the paper, but in case you're interested in learning more, here's the reference for the paper, which was published in The Lancet just a few weeks ago. Thank you very much for your attention, and I look forward to answering your questions.
Many thanks for guiding us through the presentation. If you would have any question, please use the Q&A functionality. Maybe I can get started. One finding which influences the results of the study quite substantially, and I found very interesting, is the difference between the threshold for funding a certain drug between 20 and 30,000 pounds and the kind of cost for one QALY in the UK system, which he estimated to 15,000 pounds, and that can even be considered as a higher threshold. It might even be cheaper. What is the kind of rationale for NICE of this systematic difference between what it actually costs in the UK system to generate quality and survival and what is being considered for funding? Is there any explanation for that?
Thank you for that, Matthias. So the reason why NICE has the threshold that it has, which ranges from 20,000 to 30,000 per QALY gained, is not because of any empirical evidence. So NICE has been around since 1999, and when it was initially created, when it was established, there was no explicit funding threshold that was established for NICE. And over time, it turned out that committees that were making independent decisions for funding in the NHS ended up coalescing around 20,000 to 30,000, which then became NICE's explicit threshold, not based on empirical evidence, but based on previous decisions that committee members made. And that became, therefore, NICE's threshold. And NICE has not been of course, has not been adjusting the threshold according to the health opportunity cost threshold of the health system, mainly because of political pressure, as well as the complications this would pose to industry. Because the implication of lowering the threshold to match the health system's health opportunity cost threshold would be lower prices, considerably lower prices. We estimate that incremental costs associated with new treatments would have to go down by about 42% so that new drugs are not providing a negative health impact at the population level, but they would kind of break even at the population health impact.
A follow-up question. If there is this opportunistic cost or this difference between actual kind of cost to generate qualis and the funding level for new drugs, is there evidence that in the UK other kind of health services are being decreased to kind of generate the money, which I think you estimated to 75 billion over this period, to make space to have a cap and kind of capacity for that funding? Is there evidence for reduction in other health services?
So we're not able to explicitly point out which services, which treatments have been foregone or let go to be able to release resources and funding to pay for new drugs, because there would be a very challenging exercise to actually observe that in practice. But we know that when funding pressures are being placed on payers in the health system, that money has to come from existing services. And that may result in, for example, introducing delays in the system. And the NHS has been characterized over the past few years, over the past decade actually, in terms of nursing shortages, delays in accessing medical care, significant wait lists in the system, and there are increasing pressures. But those pressures have not as much affected the pharmaceutical budgets because of this funding mandate that I mentioned in the beginning of my presentation, which says that when NICE recommends a drug for funding, payers have to find resources to pay for that drug if that drug is then prescribed. No similar funding mandate exists for other treatments and services in the NHS. So funding has to come from other existing treatments.
In your conclusion, you mentioned the trade-offs that have to be made. Is there a public discussion about these trade-offs? Because that is a trade-off being made in favor of pharmaceutical drugs. You could also say, well, a focus could be prevention, could be rehabilitation. Is that a discussion which is happening in the NHS or which is happening in England?
Unfortunately, not at the level that we would want to see, because what tends to happen is those patients who would, of course, want to have access to new treatments are visible. Their voices are quite often heard because they can take part in committee hearings. They can advocate to have access to these new treatments. And therefore, their preferences, their values are catered for a lot more than those people who tend to be invisible, who are foregoing access to treatment because funding is being diverted away from other services to then pay for new drugs at the prices that NICE considers to be cost effective. So unfortunately, we are not having those types of discussions, mainly because we're not able to point out who it is who is losing access to care, who has to forego accessing care.
I guess there's not a huge number of listeners and participants from the UK. So a question would be how could and whether you could apply the same methodology to other healthcare systems in Europe. Is that being possible or is that methodology being restricted to the NHS system?
So there are several elements that would make such a comparison possible. One is knowing the productivity of a health system. And what I mean by that is how much money goes into a health system and how much health is then produced from that additional money that goes into the health system. And those types of associational studies have been done in a number of countries in Europe. And we know how much additional money it would require to generate a year in good health in different kinds of health systems. Knowing that is a really important start for us to be able to say, then can we compare the cost effectiveness of new drugs or other modalities of treatments to how much money is being spent on other treatments and services to see whether we're generating good value for the investment that goes into pharmaceuticals versus other types of treatments. So the key ingredient for an analysis like that is knowing how much money is currently being spent to generate health outcomes in different European systems. And again, we have that estimate available for a number of European countries, but not all.
I have a question from Markus Vogt. Many thanks for asking the question. The question, I read it, is, as far as understood, the net health effect was analyzed for each individual drug and therefore rarely resulting in a positive net effect. However, the financial incentive for pharmaceutical companies to develop cancer drugs or any drugs will result in multiple new drugs, which in accumulation may increase quality significantly, even though the single drugs don't result in net positive quality. Cutting financial incentives might restrict innovation. How does this aspect be taken care of, was considered?
Yeah, that's a very important question. And the question is touching on this distinction between what us economists call kind of allocative efficiency versus dynamic efficiency. So allocative efficiency is looking at the amount of money that's available in a health system at the moment and maximizing the health outcomes we can generate for that amount of spending. And our analysis is primarily focusing on that question. Given the resource constraints on our health system in England, are we spending that money to achieve the best types of outcomes, the largest amount of health benefit for the population? The question that Marcus is asking relates to how does that then translate into dynamic efficiency? So can we incentivize also companies to continue investing in research and development, which will then reveal and yield new innovation in the future? And that balance is a really, really difficult one to strike. But the argument that I would make is we should not be foregoing health benefits of today's populations for the promise of potentially generating health benefits in the future. Because at the moment, the balance seems to be a bit off, and we seem to be prioritizing a lot of incentivizing future innovation at the cost of today's population health. And so that's the way that I would think about it, that at the moment, with the resources that we have available, the prices tend to be too high to improve population health, and they would need to be calibrated to make sure that we're not paying more for the benefits of pharmaceuticals compared to the benefits of other products available or other treatments available in health systems.
Maybe a last question. The kind of negative net effect predominantly comes, you said that it's negative for four fields out of seven, but it predominantly comes from immunology and oncology. Is there any explanation why these two fields? Is it just the number of drugs? Is it the incidence rates? So why is the net effect kind of that strongly negative for these two fields of immunology and oncology?
So our results for these two therapy areas are primarily driven by the price of products in these areas that tend to be higher compared to the value that they provide in terms of their health benefits. That the cost per health benefit tends to be higher in these particular areas. And this is particularly the case for cancer drugs that tend to have much higher prices than other therapy areas. And part of the reason for that is health systems' willingness to actually accommodate these higher prices. When you look across health systems, UK or England is by no means an exception. Cancer drug prices tend to be, on average, higher than drug prices in other areas. That severity of cancer has meant that health systems has been willing to pay higher prices for these products.
So what would be a step further to kind of increase the efficiency overall and decrease the benefit for individual patients in healthcare systems? So what is kind of a step forward to improve the situation as compared to now?
So one thing that we argue for in the paper is to make explicit the trade-off. Every time we're making a recommendation to fund a new treatment, a costly, expensive new treatment in a health system that has a lot of resource constraints, make that trade-off explicit so that patients, clinicians, healthcare decision makers can be fully aware of what is a trade-off, who is gaining and who is actually losing out on access to care as a result of that decision. That's our primary recommendation, because we understand and we acknowledge that lowering the threshold of NICE or other decision makers to the level of the health opportunity cost of the health system may be politically very challenging, because this would mean that drug prices would have to be lowered quite considerably, and that may be a medium-term objective, but at least immediately we can already advocate for making that trade-off front and center and explicit in decision making.
I guess this is the perfect conclusion for this session. I mean, make it explicit and make it known, because I guess many people have not known about these trade-offs, how they need to be made, what is the kind of quantitatively. So I hope that this webinar was kind of contributing to this discussion to make it explicit and kind of spread the word and kind of have that discussion on an open scale. Naci, Hussein, many thanks for the webinar. Many thanks and congratulations again for your work. Many thanks for joining and looking forward to follow up work of you. Thanks a lot for joining. Good
Thank you very
evening,
much.
everyone.